Hi, good afternoon, everyone, and welcome to our final webinar Wednesday of 2020. And our topic today is stress-induced hair loss, make it stop. My name is Amy Paoletti, and I'm a member of the Dutch Education and Marketing team, and I want to thank everyone for joining us this afternoon. Just to go over some of the topics that Dr. Jones is going to present on today, she's going to review your understanding of the cycle of the hair growth, review the effect of cortisol on the hair follicle, discuss the role of 5A reductase and DHT androgen pattern hair loss. She's going to briefly review other common reasons such as thyroid problems, chemicals, nutrient deficiencies, estrogen progesterone imbalance, and infection of what also may be contributing to hair loss for your patients, and also review hair restorative strategies from a conventional and functional medicine perspective. Wanted to let all of you know, just from a housekeeping standpoint, we will try to answer as many questions as possible at the end of the webinar. Please send your questions through on the questions section on the panel screen of on your screen. Also want to let everyone know if you miss anything today, we will be sending the on-demand recording along with the presentation slides tomorrow afternoon. So stay tuned for that if for any reason you miss any part of this or you have to sign off early. Give a quick introduction of Dr. Jones. I think a lot of you know her. She is the medical director here at Precision Analytical. She's also a naturopathic doctor whose passion and expertise lies in the areas of hormonal, adrenal, and thyroid health. Dr. Jones graduated from the National University of Natural Medicine here in Portland, Oregon, and went on to complete her residency in women's health, endocrinology, and hormones. She later graduated from Grand Canyon University with a master's in public health. So please welcome Dr. Jones.
Thank you so much, Amy. All right, let's jump right in, everybody. I'm very excited. One, because of the topic, stress-induced hair loss, but really we're going to talk about just all sorts of hair loss. And two, because this is the final webinar for 2020. So we're going out with a bang. We're going out with 111 slides. So buckle up and get ready and let's dive in. All right. So as Amy said, we're going to cover basically the basics of the hair so you understand, and then we're going to really go into primarily Telogen Effluvium. We're going to cover the androgenic. I will touch on alopecia. Alopecia is not my area of expertise, meaning like alopecia areata or Totalis, but I have learned a lot, and there is some amazing research out there that I think is just not circulated very widely in maybe dermatology clinics when it comes to hair loss. And so these slides, even though there are 111 of them, are definitely not all encompassing. There is a lot when it comes to hair loss. This is just to give you a solid platform of maybe things you haven't tried yet with your patients or with yourself, and things to consider, things maybe you're like, oh my gosh, I had no idea, that's brilliant, let's try that next. But if hair loss is a big part of your clinic or you're seeing it quite a bit, I strongly suggest you get into PubMed and see what's out there, because I was really excited about what I saw. So let's talk about hair. I did a post on social media. I did 2 questions just to get a gauge on what's going on with the hair situation in 2020. So my first question was, do you have active hair loss? I had hundreds respond, and 69% said yes. And many of them wrote me and said, like, it's excessive. I feel like I'm going bald. I'm getting patchy. It's, you know, horrifying. I'm crying. So this is well beyond just the typical strands that you lose every day. I then asked, are you having changes to your hair? Is your actual strand getting thinner? Is it getting thicker? Are you switching from straight to curly wavy? Are you curly wavy and you're getting straight? Are you experiencing breakage? And again, hundreds responded, 66% said yes. The large majority were thinner and breakage and loss. Not a single person said their hair was getting thicker. But I did have people ask about, yeah, actually I'm switching from straight to curly, or I had curly and now it's getting straighter, which is all about the shape of your hair follicle. So some quick hair facts. The average person has about 100 to 150,000 strands of hair and about 100,000 follicles on the scalp. And what's really cool is that as we're born with this. So we're born with our little tiny baby head, and then our scalp expands as we grow into an adult head. And how many of you were told, oh my gosh, you had such thick, gorgeous hair when you were younger. What happened? My mom said that to me all the time. She used to say, your ponytail used to be so thick. Thanks, Mom. But what happens, one, of course, your hair strand can change from thick to thin and you can lose hair. But the other thing is your hair follicles spread out over space because your scalp is expanding. So now as a kid, when your parents, did your hair, ran their fingers through your hair, it felt thick. And then as an adult, all those follicles spread out. And so it seems less thick compared to when you were younger. So throw that back in their face when they tell you that. The shape of our hair follicle determines the shape of our strand. If you have a circular follicle, you're going to have a straighter hair strand. If you have a more elliptical or curved, you're going to have a wavier or curlier hair strand or hair strand that comes out. And your hair follicle is not set in stone. It is absolutely impacted by especially hormones. So I see this a lot with women. Women will get pregnant and their hairstyle will change. They'll deliver their baby, they'll be breastfeeding, they'll move into menopause, they'll go on the birth control pill, these big hormonal shifts, puberty, right? And I see it the most with women in these shifts and its effect on the hair follicle. So if you've noticed this is happening to you or happened to you, like with one child that went straight, the next child that your hair got wavy, there you go, your hair follicle changed. Unfortunately, I don't know how to get it back and I don't know how to force the issue. So I have women that ask me, well, I have straight hair and I want curly hair. How do I make my hair follicle become elliptical shape? I have no idea. Trust me, as somebody who was born with pin straight hair, if I knew that, I would have done it to myself a long time ago. But now you know the why. And we lose about 100 hairs a day under normal circumstances, which can seem like a lot, but that is normal. Because your hair is always in a state of cycling, and so 100 is okay. The hair follicle goes through 3 different stages. Some say 4, but really the 4th is the act of losing the hair. So it's not really a stage, it's an action. So your growing phase is called the anagen stage, and this is where your follicles spend 80 to 90% of the time in a healthy state. 10% are in what's called the telogen phase, which is your resting phase, and that can last months. And we'll get more into the stages in just a minute. But our goal with hair loss is to be in the anagen stage or to decrease the conversion from anagen to telogen, or maybe if you're in telogen to speed it up so that we can start all over again in the growing stage. Your actual hair shaft, your strands, are made of keratin and are dead. Only the bulb that's in your dermis is alive and rapidly replicating cells, which is hair cells, so that you can grow your strand, hopefully, longer and longer. Your cells in your bulb divide every 23 to 72 hours. So this is why chemotherapy often causes men and women to lose their hair. Chemotherapy kills rapidly dividing cells like cancer. It also affects the rapidly turning over cells in your gut, and it affects the rapidly turning over cells in your hair. Dark hair, black specifically, is the most common globally. Red is the most rare. So where are my redheads at? I was born with carrot red hair. This is me with my great grandmother when I was a baby. It's a little hard to see in the picture, in the actual picture. My husband, when he saw it for the first time, he was like, "You have red hair." I was like, "I know, carrot red. The blonde is fake." I actually now, as I've gotten older, it has become a little more strawberry blonde, I should say. It is definitely blonded out over time, and then I just enhanced it a bit. But if you have carrot red hair or auburn hair or any kind of red hair, you are a rarity. Hair follicles themselves are like mini organs. You can see at the bottom of the picture, it says hair papilla, hair matrix, hair bulb. And again, it's that bulb that's the only living part. And then you'll see the glands in there, the apocrine sweat gland, your sebaceous gland, and then of course your erector pili muscle, which is where it makes your hair stand on end. When you get that like shivery sensation and all your hair sticks up, that's the muscle that helps it do that. So here are your phases. This is where what we need to know when it comes to hair loss and how we stop that. So anagen, not all of your hair follicles are in the same stage or phase all the time. It's not like all 100,000 of them are growing and all 100,000 of them then stop. Although it can seem that way, and in Alopecia totalis, it can be that way. But your root is dividing and adding to the growth hair or the growing hair shaft, right from the bulb at the bottom pushing up. And you're in normal healthy hair, you grow about 1 centimeter a month, and your anagen phase lasts about 2 to 7 years, depending on the person. Normally, but this can be affected. So 2 to 7 years normally. Then what happens is catagen phase. In the catagen phase, this is the 2 to 3 week transition where the bulb factory is like, whoa, boys and girls like throw in the brakes, stop, blow the whistle, like we're not doing this anymore, don't do anything. And then it cuts the blood supply. And then we move to the telogen phase where the factory goes dark and you don't grow more hair out of that strand. It doesn't fall out, it just doesn't grow. Then you get into exogen, which is where it does fall out. And when it falls out, then the new hair pushes from the bottom in the dermis and pushes out and starts over again. So you'll notice all sorts of hair loss, and then I'm sure all of you say, I have these little baby hairs. I get these little fine baby hairs. Absolutely. That's where you've switched from exogen back to anagen again. And so now it's growing at a centimeter a month. So anagen, catagen, telogen, these are your three phases. And so things make it grow and things make it not grow. So human growth factor, IGF-1, prostaglandin E2 promotes anagen growing. Unfortunately, but you could probably assume, inflammatory cytokines, TNF-alpha, interleukin-6, interleukin-1A, promote follicular apoptosis and subsequent hair loss. And then substance P, ACTH, cortisol, and prolactin inhibit hair growth. So ACTH and cortisol in stressful states are going to inhibit it. Prolactin, and this is high prolactin, inhibits hair growth. So how many of you have patients that are like, I'm breastfeeding and my hair is a mess. My hair is falling out. My hair is not growing. I don't understand why. Well, now you can say prolactin inhibits hair growth. There are things we can do, which you'll see as we move on, to maybe try to stimulate the scalp again. But again, you're competing against prolactin, especially when it's high and especially when they're breastfeeding exclusively. And so their prolactin's real high round the clock. So keep that in mind with a breastfeeding mom. Like I know sort of alleviating her fears, or she feels like she's going bald and like, oh my gosh, there's nothing, like, what can I do? There's nothing I can do. But when she's some of the things are safe that she can apply topically while breastfeeding, and other things we just sort of have to wait until she is done. But just prolactin can inhibit it. Now remember though, going back to prolactin for a hot minute, your prolactin can be high for other reasons. It doesn't have to be breastfeeding high levels, but it can be high because of hypothyroidism. It can be high, and when I mean high, I mean like mildly high, mild to moderately high. So hypothyroidism can sort of drive prolactin up. Transient stress can drive prolactin up. Now you have a double whammy. You have ACTH, cortisol, and prolactin working against you. Low dopamine, because dopamine is what keeps prolactin suppressed. So low dopamine can cause transient or mildly high levels of prolactin. And then of course, worst case scenario with high levels of prolactin, if you're not breastfeeding, is a pituitary tumor, right? A prolactinoma. So if you do find somebody with mild to moderately high prolactin, they're not breastfeeding, it's not a tumor, check out their thyroid, check out their cortisol, check out their dopamine. Hair follicles have their own HPA axis. I know, what? And I mean all hair follicles, the hair follicles on your skin, the hair follicles in your eyebrows, the hair follicles on your head. So the majority of cortisol is made in the adrenal glands. That's where the majority of your systemic contribution comes from. But right there at the hair follicle, your skin contains all the enzymes for cortisol production. It has a CRH, it has ACTH independent of the brain production, but of course it is 100% influenced by brain production. So it's called a peripheral HPA axis. And like I said, its contribution to total cortisol production is thought to be like not much. But it can be very damaging right at the hair follicle if like stress is a big factor and you're having stress-induced hair loss. Even we talk about thyroid and eyebrows, but cortisol can be a reason as well. And so many of you know with hypothyroidism, you sort of lose the outer third of the eyebrow, but keep cortisol in mind also because of this peripheral HPA axis issue. Your hair follicles can also make their own androgens, like testosterone, androstenedione. So hair follicles, sebaceous glands, and apocrine glands contain all the enzymes to make local androgens, local. 5-alpha reductase converts testosterone to DHT, which is dihydrotestosterone. Dihydrotestosterone is 5 to 8 times more potent at the androgen receptor. AR is androgen receptor. I should have put that in parentheses, sorry. So the more DHT you make, the more activity you get at the androgen receptor. And when you have more activity at the androgen receptor, that's when you get that male and female pattern baldness. So you'll lose it in the temples, at the crown, you'll get the receding hairline in men and women. There are two main types of 5-alpha reductase, 1 and 2. But in your scalp, type 2 makes 80% of your DHT, and that will be a little important as we get going later. But also, if you're looking up the literature for DHT, it's the type 2 5-alpha reductase, and there is a SNP that you can test for that as well. You have enzymes that help make androgens, 17-beta HSD, 3-beta HSD. They also play a role in hair loss. There can also be upregulated SNPs, that these are fast for you, and therefore you're more prone to having higher androgens, which can contribute to things like PCOS, but also hair loss. So by having cortisol and androgens locally in the hair follicle, it may mean systemic levels could be normal, but the local area is elevated, or both may be elevated. For women, your ovaries and your adrenal glands may be producing a lot of androgens, but so may your hair follicle. Unfortunately, your androgens and cortisol is not geotagged. So don't ask me, like, well, on testing, where did this cortisol come from? I'm going to tell you it's likely the cortisol is going to originated from the adrenal gland, because research right now doesn't think the peripheral HPA axis is contributing much to systemic, even though we have a lot of skin space and hair follicle space, that it's mostly acting locally, right, in a paracrine manner, and not getting out into systemic circulation. But that's what we know right now. We may find out later, like, holy crap, the skin is a massive contributor for cortisol and androgens. But right now, research is thinking not so much. But it does also mean if you test cortisol and androgens in somebody and they're normal, but they're having classic, like, female pattern baldness, they may have elevated androgens right at the hair follicle. But don't worry, I have some suggestions for that. Is the scalp important? The scalp is massively important. Much like anywhere else, it's the first line of defense and has its own microbiome. Therefore, your scalp is affected by pollution, chemicals, what do you put on your hair, how often you wash your hair and with what, how you treat your hair. Example, like, right, flat ironing it all the time, or I was reading, it's called traction alopecia. Traction alopecia are like the classic example are dancers, cheerleaders, where they have their hair in really tight ponytails and it's pulling on their hairline constantly, and so it's literally drawing it's affecting their scalp and it's affecting their hairline. And so how you treat your hair, how you style your hair, sunburn on your scalp, and more. Blood supply to the scalp affects the hair follicles. If you go back to the picture in the beginning where I showed the hair follicles, you will see all the little capillaries running through there. So if you have poor blood supply in your body, if you have poor blood supply up to your scalp, then it is going to affect your hair. So there are 6 common types of hair loss. There are other types, they're just less common. And I just want to point out the 6 common, though, in our time. So we have telogen effluvium, which is that diffuse, when you feel like a dog, and it's just like every time you run your fingers through your hair, you shed. It's always on the back of your sweater, your hoodie, it's on your pillowcases, you shower, and it like comes out, kind of from all over. Alopecia can be areata, which is patchy, or totalis, which is when you lose it out of all of your hair. Alopecia totalis is different from chemo-induced totalis, because alopecia is autoimmune versus chemo is, of course, medication-induced. Androgenic alopecia, that's the male or female pattern baldness or thinning. Tinea capitis is what they call ringworm of the scalp. Trichorexis nodosa, this is secondary due to trauma, usually often like chemicals, styling, it's with the breakage that your hair strands don't fall out, but they break. It can be genetic and it can be for other reasons. It doesn't have to be chemicals, but chemicals are the most common, or heat, things like that. And then, of course, trichotillomania, which is the hair pulling or hair plucking disorder. You can have more than one type of hair loss. They can overlap. You don't have to just narrow it down to one. And what we're going to talk about is telogen effluvium and alopecia mainly, with a little bit of androgenic. And just know that trichotillomania does fall under the cortisol category if it's stress related. But trichotillomania has an OCD aspect, an anxiety aspect, it could be stress related aspect. And so I'm not going to talk about trichotillomania, but just know if cortisol is high and it's how they stress response, then you're going to have this part of how you're going to address the cause. But we're going to stick in the top 3. So telogen effluvium, what are the reasons? They're broad and many. So chronic or acute illness, think hypothyroidism, diabetes, especially, of course, uncontrolled diabetes, Infections, stealth or overt, it doesn't matter. Stress, like this whole year. Elevated mast cells, so think your mast cell activation syndrome, or maybe this person's just an allergic person, lots of mast cells, mold, mycotoxin, what have you. Pregnancy and childbirth, you get that blowout on delivery, so your hair is lush and gorgeous and beautiful while you're pregnant, and then you deliver and start breastfeeding and all your hair falls out. It's like, what the heck? Like, who designed that? That was terrible design. Iron, low iron, other nutrient deficiencies like zinc. Mental, emotional, physical stress, inflammation in the scalp or follicles themselves. So even though I mentioned tinea is its own subject, tinea can still fall, like they can kind of overlap, but also think eczema, right, in the scalp, think seborrheic dermatitis, think of other things that can cause inflammation in the scalp. High prolactin, we talked about, eating disorders, disordered eating, sudden or extreme dietary changes. And I actually had a message today from somebody who said they switched to the carnivore diet and it's helped their hormones immensely, but she's losing hair like crazy. And I was like, it's what happens. And it doesn't mean it's necessarily wrong or bad. It's just, it's going to take months for the body to get back to normal. Other people I've had tell me that they did like the 7-day fasting mimicking diet. They decided to try to go vegan or vegetarian. They switched to paleo. They went gluten-free. And again, I'm not shaming any of these ways of eating at all. I'm just saying to go from your normal that your body is used to, and then you completely change drastically in some cases, can be enough for the body to go, whoa, let's not put the emphasis on hair growth right now. Like, let's figure out what he or she is doing with how they're eating, and then we'll go back to hair growth. Major surgery. Or certain medications and illicit drug use. Now with Telogen Effluvium, it usually doesn't kick in for 2 to 6 months, meaning if you got pregnant, delivered in May, and then in July, you're like, wow, my gosh, where's all my hair? Or 2020, people will say, I was really getting messages starting around like the June, July, August timeframe of how much hair loss women mainly were experiencing, and knowing the pandemic started in March. Medications, I have people that say, I started a medication a couple months ago and now I'm having lots of hair loss. Could it be related? And it could be, but you want to make sure you check everything else out as well. So just as a FYI, according to WebMD, I wanted to know what medications could cause hair loss. It was kind of basically all of them. It was all the common categories, right? So we have, like acne meds, antibiotics, and antifungals. Even though interestingly, antibiotics and antifungals can be used for hair loss depending on what the cause is. Birth control pills, I did get anecdotal messages from women who said I either went on the pill and lost hair or went off the pill and lost hair. But again, hormone shifts will do it. Antidepressants, hypothyroid medications. And the reason for hypothyroid is if you're on too much or too little. It's not necessarily the medication itself, it's dose dependent. Cholesterol lowering meds, immune system suppressant meds, which makes sense. Anticonvulsants, anti-clotting medications, and which was actually interesting to me because anti-clotting would mean you have better capillary flow, but side effects. NSAIDs, steroids, weight loss medications, and chemo for obvious reasons. Focusing on cortisol though, so with cortisol, we know already that you have systemic and local cortisol effect right there at the follicle. So high cortisol reduces the production of hyaluron, glycosaminoglycans, and proteoglycans. There's 2 in particular, Versican, lectican, and decarin. And so when you reduce the production of these, what can happen is you get perpetually dry skin, like in the scalp, and poor hair cycling signaling. So the hair doesn't know to go in the growing phase, or it doesn't know to move out of the resting phase. So you have a short anagen, so short growing and long resting, and then it falls out, and then and then the anagen phase is short again. So you're not actually ever getting to the length that you want or feeling like your hair is growing. And this is what's happening a lot now with the sheer amount of stress that the pandemic has put on everybody, is that they're getting poor hair signaling. And so on top of everything else men and women are having to deal with, they're also experiencing hair loss, which stresses you out even more. Cortisol and inflammatory cytokines, this is a no-brainer. Increased inflammatory cytokines increases cortisol production. Cortisol is anti-inflammatory to a point. But now you have high cortisol and high inflammatory cytokines, so you get increased telogen effluvium. So you get that diffuse shedding or hair loss. And so any kind of inflammatory disorder, no matter if it's stealth or overt, chronic or acute, coupled with cortisol is going to push you into that shedding. Now, CRH, cortico-releasing hormone, which is from the hypothalamus. So CRH degranulates mast cells. So CRH tells the pituitary to make ACTH. And so when you get the signal to the brain, like, man, there's a lot of stress going on, or inflammation, or their blood sugar's low, let's make more cortisol, CRH goes up, and then mast cells degranulate as a result. Some people have high levels of mast cells in their scalp, and when they degranulate, you shorten the growing cycle and lengthen or increase the conversion into the catagen or fallout cycle. And so for those of you who are struggling with mast cells, mast cell activation syndrome, maybe you notice more hair loss in allergy season, in the spring and the fall. You're like, what the heck? My eyes are watering, blowing my nose, and my hair is falling out. Like, this is so not fair. Mast cells can be a big reason in the scalp, and cortisol can go with it. All right, moving from telogen effluvium, let's talk about alopecia areata and totalis. So the National Alopecia Foundation states 6.8 million in the US, or 147 million worldwide have alopecia. I believe I read today that your like lifetime chance of developing alopecia is 2%. And children between 5 and 12, I believe, is 3%. I would have to look that quote up again, because alopecia totalis, even in areata, is an extremely common reason that children visit their doctor, the pediatrician or functional practitioner. Now, this webinar is 100% geared towards adults, just because Dutch test is a, like teenager and above type of test, but wanted to put that out there. With alopecia, it's predominantly thought to be a CD8-driven Th1 type T-cell autoimmune reaction, but that is debatable depending on the literature you read. This is what I read the most often, though, and it seems to be the most commonly agreed upon. There is often a genetic component of alopecia areata in totalis. So if mom had it or dad had it, or it runs in the family. Environmental triggers are common. So Epstein-Barr is EBV, cytomegalovirus, and other viruses like the current virus. I'm sure many of you are now starting to hear about post-COVID hair loss. Obviously, there's post-COVID syndrome, but hair loss is wrapped up in that as well. Mold and mycotoxins, bacteria, mast cells again. And then, like I said, totalis is the advanced form of alopecia areata just being patches. Alopecia being autoimmune, it's sort of linked with other ones. So make sure you're on the lookout for these as well. Or if you have these, or your patients have these, and they're starting to lose hair, know that there's a serious crossover. So celiac, rheumatoid, type 1 diabetes, Graves, and Hashimoto's both, vitiligo, lupus scleroderma, and ulcerative colitis. So these kind of the family of autoimmune that run together that you will see consistently in the literature. It doesn't mean just because you have one, you're going automatically to develop, but the percentage can be kind of high that you might. And so as practitioners, be on the lookout for this. And especially because we're talking hair loss, especially with hair loss. So this study that was in 2013, what causes alopecia areata, I thought it was really interesting. The onset of alopecia areata likely requires input from multiple factors: genetics, stress, hormones, diet, infectious agents, vaccinations, etc., that determine the physical and biochemical status of the immune system and hair follicles. Now, the whole point was about alopecia areata, but of course you could insert really any autoimmune condition in here and the quote would still apply. All right, now let's move on to androgenic alopecia. Androgenic alopecia is different. It's not autoimmune. It's due to androgens. It was first observed by Hippocrates in 400 BC. That's a long time ago. And his first observation was in men. And so men have been dealing with this for a long time. Women, we call it female pattern baldness, men, male pattern baldness. So elevated androgens like testosterone bind to that androgen receptor. Now you can also have that 5-alpha DHT bind to the androgen receptor. You can also have normal androgens and an overly sensitive androgen receptor. It just like, every little thing makes it trigger, right? Everything is like, it binds to your androgen receptor and poof, you get hair loss. And it's often genetic, androgenic alopecia. So men and women can often look in their family and go, ah, dang, that's coming. I can see it's coming. And I primarily would see women, and I would have women say, my mom went into menopause and she's getting hair loss and I don't want that. Like, my mom, my aunt, my grandmother, like they all kind of lose their hair the same way. I'm like, let's see what we can do. But we're fighting genetics, so we'll do the best we can. It is important to note that high prolactin can cause similar hair loss patterns. So don't automatically assume all male pattern and female pattern baldness is due to androgens. Make sure you check their prolactin as well. Yes, men can have high prolactin. Again, thyroid, stress, dopamine, tumor. Clearly, they're not breastfeeding. Androgens and hair loss. So androgens cause hair loss in places like beards and pubic hair, or excuse me, hair growth in places like beards and pubic hair, but loss on the scalp. How many men do you know that go, yeah, I'm just losing it from my hair and it's going down to it's moving down to my beard or into my ears or in my nose hairs. My nose hairs are growing, but the hair in my head is not. I hear that from men all the time. DHT especially causes what's called hair follicle miniaturization, and that's the hallmark of androgenic alopecia, the miniaturization of the follicle. We don't want the follicle to become miniaturized, right? Like miniaturized ponies are cute, miniaturized hair follicles are not. So we don't want this. But what happens is the anagen phase gets shorter, the telogen phase gets longer, or the blowout phase increases, and now the hair shaft growth slows until it doesn't grow anymore with each hair follicle. It kind of skips follicles. And then the hair follicle shrinks, which is miniaturizes, resulting in smaller, finer hairs. So when you still have the smaller, finer hairs, it is possible to maybe partly reverse it and get that hair follicle to continue to make hair. When no hair grows out of the hair follicle, then reversal is extremely unlikely, and you're looking at just living bald or something like a hair transplant. So if you forget where the androgens are, this is the steroid pathway that's included on every single Dutch test result. It's generic, but it's to show you how everything works and then what can activate and what can maybe deactivate or slow down. So if we focus right in on the androgen section, you'll see the 5-alpha reductase, 5B or 5A, 17-beta HSD, and that 3-beta HSD, and they all help make all the androgens right there. So if you have any kind of polymorphism in there, or if you're doing things on either unknowingly or knowingly to stimulate these things, then you're going to end up with more androgens, and you could have more androgenic hair loss. So what increases that 5-alpha reductase besides genetics? Inflammation, especially in the scalp. So what are you using to wash your hair with? What kind of products do you have? Do you have fungus? Do you have alopecia, androgenic alopecia and tinea? Do you have, other kind of bacteria or fungus in your scalp and you just don't realize it? Seborrheic dermatitis. Elevated insulin, hyperinsulinemia will increase 5-alpha reductase, PCOS, and it's generally, of course, the insulin version of PCOS or inflammatory version of PCOS. Hypertriglyceridemia will increase it. Obesity, because of the inflammatory cytokines that the white adipose tissue puts out. And this is the polymorphism I was mentioning earlier, that type 2 5-alpha reductase. It makes more DHT, which is the potent androgen, compared to type 1. And interestingly, type 2 is more active in a more acidic pH, so 5.5 pH. So if you have androgenic alopecia, when I talk about later as we get into treatment, is that, maybe looking at shampoos and waters and stuff that will make your hair a little more basic, so you can slow down this activation. Androgenic hair loss in the areas, you've got, temple, the hairline, the middle part, and the vertex. So in those areas, women tend to lose it in the vertex and the midfrontal first, and men tend to, it can do all the places. But for a female pattern, it tends to start in the back and save the front, but you can, it can be both at the same time. So let me show you just two common case examples, and then we'll get into treatment. So 22-year-old female with female pattern hair loss, started in puberty. She started doing the comb over hairstyles. She has hirsutism on her chin, neck, and nipple. So she's losing hair on her head, but gaining hair in other places she doesn't want. She was diagnosed with PCOS a year ago, hyperandrogenic oligomenorrhea. She does have high insulin confirmed on fasting blood draw, and her doctor advised her to go on spironolactone for the hirsutism and the hair loss, and the birth control pill to regulate her cycles. She does not want to do that. She ran a Dutch test. I'm just going to focus in on the androgens, and you can see that the 5-alpha reductase activity of the little gauge that is leaning off to the right in the green, she heavily favors the 5-alpha, and her 5-alpha, one of her markers, her androsterone, is also elevated. Her DHT, which I for some reason forgot to show you, was elevated as well. And so this is a classic example, right? High insulin stimulating the 5-alpha, she's PCOS, and so we're going to work to try to lower all that. That's in contrast to this woman, 45-year-old woman with hair loss since August of 2020. Stress has been a 10 out of 10 all year, scared, anxious over the pandemic, now working from home. She didn't have a home office set up. She wasn't ready for it. It's been a scramble. And oh, by the way, she has 3 kids doing homeschool that are 6, 10, and 14. God bless her. She's unable to rely on family for help. She's trying to social distance, and as a result, her sleep is terrible. Do a Dutch test on her. If we just focus on the cortisol part in the time that we have, her cortisol, of course, is through the roof. So her metabolized cortisol, which is total cortisol that's made metabolized through the liver in a day, is on the upper end of the range, which makes sense. Like, of course, her adrenals are going to be producing and making and clearing a lot of cortisol. What's free and active and available, this is the Dutch Plus that she did, is 29.69, and 19 is the cutoff. It's pretty elevated. Like, she's making a lot of cortisol, and she tends to focus it there in the middle of the day. So the blue line, she is the blue line, and the black line are the upper and lower reference range. If you're not familiar with the Dutch Plus, which I will talk about in just a second, but the Dutch Plus, we heavily focus on the cortisol awakening response, which is where you do 3 salivary collections on waking. You do 1 on waking, 1 30 minutes later, and 1 30 minutes after that. So within the first hour of waking, you've done 3 collections. And the reason is I want to see, how do you start your day? And she starts her day by going from 0 to 10, which is how she feels. And then it stays up pretty much until she gets into the afternoon, and even then she rides the high end of the afternoon. But think about it, she gets up, she has 3 kids to get ready for homeschool and her own job, and no one to help her. And of course, not only is she losing hair, but obviously other things are happening as well. So when it comes to growing hair, it's super complex, but not critical for survival. You would think you might want hair for warmth as part of survival, but the body disagrees. You don't need it for survival. So the body will divert blood supply and nutrients away from hair follicles when it is threatened or ill. So when people say, why do I lose my hair? Why, what's going on? Why is 2020 I'm having hair loss? Or why with all this stuff? It's because any sudden jolt or a sudden shift, and the body's like, whoa, hair's not a priority right now. Let's stop and see, let's stop and observe and see what happens, which is why it can take months. So common treatments for hair, medications are, minoxidil and finasteride. You've got your 5-alpha reductase inhibitors, like anastrozole. Topical and oral anti-androgens like spironolactone, which is what the first case was suggested. Topical antibiotics, if it's, inflammatory or bacterial, antifungals, anti-inflammatories. Low laser level therapy to the scalp. Red light and near infrared light, it's gaining in use even in conventional medicine, even though it's really well used in functional, precision medicine. PRP, platelet-rich plasma, this is also gaining in use in conventional medicine, and then of course hair transplants. And many of you might actually do these already. Many of you may already be doing red light, near infrared light, low level laser, PRP to the scalp is part of your practice. So with hair loss, there are 2 goals. Your first goal is to keep your hair in the anagen phase, right? We want it growing. We want to reduce the conversion to the telogen phase. And then we want to, if you're in the telogen phase, we want to reduce the time there and just get it to the catagen, get it out, so that you can get back on the anagen and then keep it there. And so that's number 2. Let's stimulate new, better growth from the follicle. So like I said, the telogen phase can last 2 to 6 months on average, depending on what you read. My hairdresser told me last week when I saw her that she said she thinks it can last up to a year. She's like, I've definitely seen people going through big sickness, big illness, big divorce, and it can take a year before the cruise ship turns, which is always my analogy with hair. Like, just like cruise ships, it's slow. Turning a cruise ship is slow, and it's the same for hair. So first and foremost, what do? You have to address the cause as best you know it. So if they have hypothyroidism, if they're iron anemic, if they've got high levels of mast cells, if they're not doing well with their diabetes, if they're low iron, if they have the Prolactin, if they just change their dietary plan for whatever reason, if they've just come out of surgery, if they have tinea, check their products. Maybe they maybe they moved into a new place and the water in their house and their new place is really hard or full of chemicals and it's affecting the scalp as opposed to their old place. You know, maybe they switched up their styling habits. They're using a whole new product on their hair, and they started that 4 months ago because they saw somebody on YouTube and bought the same product, and now their hair is starting to fall out. So all these things require some digging on your part, and you may just have to go through a questionnaire check like, hey, in the last 2 to 6 months, have you? And then we're going to support them from there. So next, because you are watching a Dutch video, we are going to talk about the Dutch test you're going to test. Because our focus is on the androgens and cortisol, but I also said that hormone shifts are a big reason for that telogen effluvium. You're going to consider using the Dutch Plus to look at all of those hormones. So if you are new to Dutch, let me just take a couple slides to introduce you to Dutch. And if you are a Dutch enthusiast, then just hold on for a second and we'll keep going in through treatment. So Dutch, when we look at Dutch, you have options. Dutch is an acronym. It stands for Dried Urine Test for Comprehensive Hormones. And it is dried urine, or if you do a Dutch Plus, it's dried urine coupled with salivary swabs. What you get in dried urine or dried urine in combination with the salivary swabs is very comprehensive. It's everything compared to maybe serum or compared to maybe saliva. Because of the urine, you're able to get not only your typical hormones like estrogen or progesterone or the androgens, but you get the metabolites. So you get estrogen and then you get to know where it goes through phase 1 and phase 2 estrogen metabolism. You get testosterone, you also get DHT, and you get that 5-alpha reductase gauge. You get your cortisol, which I showed you earlier, but you also get metabolized cortisol, which is a pretty rough look or healthy look, I guess. It represents about 80% of total cortisol production and metabolism in the body. But we also give you free cortisol and free cortisone. So how much is active and doing its thing and how much of it's getting deactivated? Maybe your patient, in another example, has low cortisol, not because they can't make it, but because they're deactivating it. We do give you the cortisol awakening response, which is important in the case to show that woman goes from 0 to 10 in about 30 minutes. We give you extra organic acid markers. We give you 2 B6 markers, a B12 marker, specifically the adenosyl B12, which is the B12 for the mitochondria, and a glutathione marker. We do look at the metabolites for dopamine, norepinephrine, and epinephrine, known as HVA and VMA. 8-OHDG is an oxidative stress marker, melatonin, and then for those women who need it, we have the cycle mapping where they collect almost every day of their cycle in the morning, and then we can graph out their estrogen and progesterone all month long. So it's pretty comprehensive. This is what the collection device looks like. If you're new to Dutch and don't know, you can either urinate right on it or collect your urine in a clean cup. It doesn't have to be sterile, just clean. And then you can dip the paper in there till it's saturated like that. Now, I mentioned we do have a split test, the Dutch Plus, which is where we look at dried urine and saliva. When we chose saliva, we looked at saliva swabs as opposed to tubes. The problem with tubes is that you have to spit or drool into the tube. It can take a while to spit or drool into a tube, and that could affect the accuracy of your cortisol awakening response because timing is everything. Some companies do advise you rinse your mouth out with water prior to spitting in the tube, and that could, depending on user error, lead to dilution of the results. With the swabs, you just pop the swab in your mouth. You get the truer cortisol awakening response result because you can just pop it in, leave it in, get it wet, stick it back into the tube, and done. And then you can do it again very quickly. You don't have to spit, you don't have to drool. It's very convenient for those with dry mouth, and it is the form that's used in research. So that's why Dutch has chosen to go that route, because it's so much easier and a truer collection. So is there research regarding dried urine? Yes, in 2019, Dutch was published comparing dried urine against serum estradiol and progesterone, and showed that you could see there's serum progesterone and urinary progesterone on the top, serum estradiol, urinary estradiol on the bottom, and there's great correlation there. And just recently, published this month in December 2020 in the Journal of Clinical and Translational Endocrinology, looking at the difference between salivary cortisol and dried urine cortisol. And they found there's a statistical equivalence between the rise and fall in both. Now, you may be looking at that pattern and think to yourself, but they don't line up. How is that statistically equivalent? Excellent question. The reason for that is saliva cortisol is in the moment, right? It's what's in your salivary gland, and you're just going to spit it out. Urinary cortisol is what you have made, has gone through the kidneys and into the bladder. So there's about a 2-hour lag time between what's in your saliva glands and what's in your kidney. And so that shift in between is about a 2-hour shift. But if you overlap them, then that's where the statistical equivalence comes from, which is why with Dutch, we have you collect on waking, which really reflects through the night, and 2 hours later, which catches everything in that 2-hour window, if you do the all urine test. So choosing the right test, we do have the Dutch Complete, which is all urine all the time. 4 urine collections throughout the day. There's a 5th overnight collection if you have insomnia. It covers all of the hormones I mentioned. The only thing it doesn't cover is the cortisol awakening response specifically. It does test cortisol, but not waking 30-30. The timing is a little bit different. That leads us to the Dutch Plus, which is the combination of the two, which is what in today's webinar, the example I gave was of the Dutch Plus, because I wanted to see on waking 30 minutes later and 30 minutes after that. I really wanted a really microscopic look at the cortisol for that case. So this one, you still get all the same hormones, all the same metabolites. You do get cortisol, but this time the timing is different, and it is the cortisol awakening response. If your patient has insomnia, don't worry. We still give you the extra overnight sample so they can test for insomnia as well. So the Dutch Plus is more comprehensive because it's urine and saliva. You do get more data points on your results. So it is more collection. There's more your patient has to do, but you get lots more information. All right, so number 1 was address the cause. Number 2 was test, see what's going on. And now you're gonna support the scalp. So third, support the scalp. How do you support the scalp? Well, generically, there's a lot you can do, right? Scalp massage or gentle brushing on the scalp, or getting one of those, like, you know what I mean? I think I have one. It looks like a daddy long legs, you know? And then you like do the scalp thing, massage up and down. But for some reason, it's way better when somebody else does it to your scalp versus when you do it to your own scalp. But that kind of thing can help with scalp massage. Don't let product, oil, or dirt build up too long. It clogs the follicles, it weighs down the strands, and it can cause mild inflammation. I am 100% guilty of that when it comes to washing my hair, working from home. In fact, I asked on social media what the average time was that men and women wash their hair, and by far, twice a week was the most common response that I got. Some people was once a week, some people was every day, but by far, most everybody washed their hair. Shampoo washed their hair, not took a shower, but like fully shampooed their hair twice a week. And for some of you, that's not enough. And for some of you, it's maybe too much. And so you have to play with that. Inversion poses, think like yoga, if you can do it. Forces or if you have one of those inverter, you know, you like strap yourself into, and then you can flip upside down. It forces blood to the scalp. Alternating hot and cold to the scalp for stimulation, which might be nice in the shower. So ending on cold, or mildly cool, and making sure to get the scalp for that stimulation. Acupuncture, chiropractic, massage, lymphatic stimulation, especially to the upper back, shoulders, and neck. Anything that improves blood flow up and down through here is going to be really helpful. So I say this every time. I'm going to say it again. When you're watching this webinar right now, I want you to stand up straight. I want you to pull your shoulders down. They are not earrings. And I want you to pull your chin back, because you probably are looking forward or in some crazy position listening to this webinar. So do all of that and make sure you're breathing deeply. Stop smoking. We know smoking, the chemicals in smoke gum up the works, and reducing blood sugar and addressing diabetes. And I think, oh, for some reason well, anyway, wonder why that didn't save. I also included here, this is where you would also do like red and near infrared light therapy and like PRP to the scalp. I don't know why that didn't save, but I have mentioned it before. So this is where you would also do those two things. So if you have red and near infrared light, you know, putting it, you know, right up against the scalp can be helpful. Oils. Those of you who like oils. So obviously there's a few oils. I just looked at 2 just in the interest of time. So rosemary oil, antioxidant, anti-inflammatory, improved circulations in the skin in a rat study, and peppermint oil. So in a 4-week mouse study, they found that peppermint essential oil showed the most prominent hair growth effects, a significant increase in dermal thickness, follicle number, and follicle depth. And you can use both. Now be careful, always have a carrier oil, or do a couple drops in your shampoo and conditioner or your hair mask. Maybe don't put the oil directly on your scalp, that might burn it. Always make sure that you test to make sure you're not allergic to these oils. And yes, there are other oils like lavender oil, right? But these are the 2 that come up over and over and over again. when you're looking in the literature. So a little bit of rosemary and a little bit of peppermint. Obviously sourcing counts. Please don't buy crummy oils. Castor oil. Castor oil is by far one of my favorites, even though it is goopy and it gets everything messy. So oil from the beans of castor oil, and topically it can dilate blood vessels through stimulation of the prostaglandin E2 receptor. And as we know, prostaglandin E2 is a stimulator for hair growth, and it can be anti-inflammatory. So castor oil couple drops in your shampoo or conditioner. Just running castor oil through your scalp, you can put that directly on. Use it as a hair mask. Use it as your carrier oil for your rosemary oil, your peppermint oil. It is an oil, so please make sure you're getting it organic, cold pressed, hexane free, and a glass bottle. It's an oil. Why would you get it in a plastic bottle? It's just going to pull the phthalates in and anything else that's in that plastic bottle. Castor oil, like I said, is messy though, so it is kind of a pain. If you do a full-on hair mask and you're trying to wash it out, you're going to feel like you have to wash 16,000 times. So just be aware if you've never used castor oil before. But it is amazing. It is amazing. I rub castor oil just using my finger. I rub it on my eyebrows and just gently over my eyelashes to help stimulate hair growth there as well. Anti-inflammatories. We've been talking about the scalp and anti-inflammatories. Topical curcumin, anti-inflammatory, immune modulator, mast cell stabilizer. It is curcumin, right? It's turmeric. It looks like that. It will probably stain your skin. Be careful of your clothes and your towels. But if you have topical turmeric, topical curcumin, and you're doing some sort of hair mask or you're spot treating for even like alopecia or what have you in the temporal region, then, mix it with your rosemary oil, mix it with a little castor oil and spot treat yourself in there. Topical ginger, I did read anecdotally on blog posts that topical ginger can work, but the research shows there's no help and maybe even suppresses hair growth in mice. And so I'm just going to leave that there. I don't know that I ever had patients tell me topical ginger was helpful or that it worked for them. You may have experienced amazing results with topical ginger, but I just wanted to put that out there, that I didn't find that one to be amazing, despite the fact that ginger is anti-inflammatory. That's why I looked up ginger, because I was like, well, if turmeric, let's look at other anti-inflammatories. And so be careful. Stick to the turmeric maybe. Scalp support for hair loss. Oh, well, here he is. PRP, platelet-rich plasma injections. And so if it works well. And if it doesn't work, unfortunately, then it doesn't work. I have had a number of people who 50-50. I have had people say, I tried it and it worked amazingly well. Some of you do it in your clinic and have fantastic results before and afters, and other people don't take to it. It doesn't work for them. But there is good research on it. So that's an option. And then another, if you're doing microneedling, if you do microneedling in your practice, using Ganoderma, so reishi mushroom, do liquid tincture of reishi mushroom, and it was set in this example, Ganoderma and microneedling were more effective than microneedling alone in hair growth activity and useful for treatment of alopecia. So this was in mice, but you can get really good quality liquid reishi tinctures that are free of mycotoxins and tested for everything. So just be careful of sourcing. So if you're already doing microneedling in your practice, add a little liquid reishi in there and stimulate that hair growth. And you could even potentially, I didn't find the study of reishi by itself, because obviously there are companies that make reishi liquid, just like liquid turmeric, curcumin, right? I didn't find studies of using reishi by itself and just like putting reishi all over your scalp. Doesn't mean you can't try it, practitioners. All right, other studied herbs, nutrients, unsuspecting meds, and more. This is not an exclusive list. We only have 60 minutes, and I'm going to run a little over. Those of you who are into peptides, GHK copper in the scalp has been shown to be helpful in growing hair. You can get this over the counter. You can get it online. Please be careful of sourcing, because there is some crap out there where it's fly-by-night companies that are trying to jump on the peptides that are allowed to be sold basically over the counter. You want to make sure you get it from a reputable source and that it is actually this peptide. And because of the copper aspect, you have to be careful of copper toxicity. Consider adding zinc. That's more if you do it orally. So you can do it, it's an oral peptide, or it can be a topical peptide, or like even like I see it in gels and creams as well. But this you can see in 2018, and its help on like look at that collagen, elastin, glycosaminoglycans synthesis. The other good peptide is thymosin beta 4. Thymosin beta-4 accelerates hair growth in part due to its effect on critical events of the active phase of the hair follicle. Go anagen. So if you're using thymosin beta-4 for other reasons, you may notice that your patient's hair could improve as well. Polygonum, FOT, right? Written about health and hair since 812 AD. In fact, it's been written about longer than that, but specifically, I think the earliest hair writing is 812. So I think that's pretty cool. In animal studies, Polygonum, this is a supplement that you can take orally or topically. But topically, it showed to increase hair follicles. It pushed you into the anagen phase, which is good. It slowed the conversion in the telogen phase, and it inhibited hair follicle apoptosis. In cell studies, it improved the house of the bulb, right, and the mitochondria in there. It reduced the conversion of anagen to telogen, so kept it in growth phase. It increased VEGF, which is your growth factor, one of your growth factors. It reduced the DHT effect in androgenic hair loss, so that's pretty awesome. And it's been written about forever in Chinese literature to stop or reverse premature graying. So Polygonum, you can consider that. You know what? I don't think I included human studies. I didn't. Animal studies and cell studies. Sorry about that. It's been around forever. It's been in a lot of humans have definitely tried it, but try it, topically and orally. Oral silicone. It improves connective tissue, improves tensile strength and elasticity of hair strands. This is probably one of my personal favorites. If I ever personally have hair loss, this is one of the things that I do, and I found that it makes a world of difference. I find that for the oral silicone, I find the liquid works better than the capsule. I'm assuming it's maybe absorption issues with myself and patients. The liquid does taste terrible though, like terrible. So just warn them if you're going to go that route. Oral collagen. Collagen is being used for lots and lots of reasons. Collagen provides peptides that stimulates collagen production itself. It improves skin elasticity, increases glycosaminoglycan production, which remember, cortisol decreases that and then causes hair loss. And improves skin hydration. Just like everything else we talk about, quality counts. So make sure whatever collagen you're getting, they do test for junk, and that there's actual collagen in there, and that it's grass-fed and there's no mold or bacteria or heavy metals or other kind of like junky things that get snuck in there. So make sure if you're going to do collagen, do a good type. And then there's proteoglycans. So proteoglycans, you will see there are a few products on the market, which I won't mention, you can find yourself. And so they've been looking at proteoglycans for skin health for years. And in non-sponsored study, they found exogenous administration of that decarin. Remember, cortisol decreases this, which pushes you into hair loss. So if you get an exogenous administration of decarin, it accelerated anagen and delayed catagen. So it stimulates the hair growth cycle, which is good. In one of the product studies, of course, sponsored product study looking at proteoglycans like decarin, improved androgenic alopecia and telogen effluvium. So I gave you both, and the studies are linked there. You can read for yourself and find that if it's of interest to you. Vitamin D. Vitamin D is a hot topic right now, considering the situation, but they did find vitamin D can improve female pattern hair loss, and that women with female pattern hair loss often had lower levels of vitamin D. And so making sure that when you're checking vitamin D, asking them about hair loss and just seeing if it correlates as you get their vitamin D levels back up there again. Antihistamines and alopecia areata. So 24 patients, this is a human study, were given 180 milligrams of fexofenadine, which is Allegra, for 7 months, and topical corticosteroids with superficial cryotherapy, and they exhibited major hair regrowth, their words. 79.3% treated with only steroids and cryo had regrowth, no fexofenadine. So they found by adding in the antihistamine support that even though they had really good luck with the steroids and the cryo, adding in the antihistamine support just made it that much better, which is pretty amazing. And it's a 2020 study. I have it listed there. There's another study looking at fexofenadine by itself with alopecia areata, and because it's an obviously H1 receptor antagonist, it decreased interferon gamma and inhibited IL-4 induced expression of IL-5 and was helpful at regrowing alopecia areata hair loss. which also made me think, what about topical antihistamines to the scalp? There are plenty of different topical antihistamines out there. I didn't see any studies on it, just on, I mean, there's topical steroids, obviously, that they'll use for Areata, where you can spot treat the patches. But what about topical antihistamines at the same time? Which then led me to quercetin. We got some big players in the supplement world when it comes to being a natural antihistamine. So I looked up quercetin and alopecia areata. This is poor little mice, but mice injected with quercetin and the DMSO was the carrier had hair regrowth. So you can see the sham mice on the left with the alopecia areata and the quercetin treated on the right, and all their hair grew back using quercetin. So that's another thought for those of you, maybe topical quercetin, or quercetin is part of your microneedling program, oral quercetin, especially if you know that mast cells are an issue. Low-dose naltrexone in alopecia. Low-dose naltrexone is amazing. It's being used for a lot of things. Unfortunately, what I found is it's not a single study describing its use in alopecia areata, because we use low-dose naltrexone a lot in autoimmune. However, the study says that patients and prescribers are still using it. Because the presumed mechanism is anti-inflammatory, LDN can be potentially useful in inflammatory stages of alopecia areata and other alopecias. So for those of you who are using LDN, maybe with thyroid or with ulcerative colitis or with other whatever, check in on hair growth, maybe really affecting or improving their hair growth. But apparently no human studies specifically looking at LDN and hair that I saw. Still worth a shot. Now, what if androgens are the issue? So we talked a lot about like scalp options, topical options, anti-inflammatory options, antihistamine type options. Like what if it's androgens as well? So you're going to address the cause. So maybe that turmeric in the scalp, right? You're going to look at anti-inflammatories for the scalp. You're going to address their insulin, their PCOS, their triglycerides, the inflammatory cytokines from obesity, scalp acidity. Maybe you're going to look for higher pH shampoo. So I looked into this, since I'm not I'm not in cosmetology or hair, and I didn't know if shampoos are required to have a certain pH, and they're not. It's unregulated. You can make any shampoo you want. There's no regulation other than like don't kill the person. So there are definitely low or acidic shampoos and basic shampoos out there, runs the gamut. So you're going to have to research for people shampoos maybe or conditioners to maybe get their pH a little higher, a little more basic out of the 5.5 range if androgenic alopecia is an issue, because we know the type 2 is more active in that 5.5 range. You also might want to test their water. What's going on with their water? Maybe they need a shower filter or a whole house filter, right? Like maybe they've moved, and as a result, the water that's affecting the pH of their scalp and the health of their dermis. But 5-alpha inhibitors that are non-prescription, other than, prescription are things like finasteride, right? So the non-prescription, we have saw palmetto, we have stinging nettle root, we have Pygeum africanum, we have EGCG, we have green mushroom, reishi mushroom, Ganoderma, beta-cytosterol, and you can consider all of these orally or topically. We think of them orally the most by far when it comes to reducing DHT and 5-alpha reductase. We think of oral saw palmetto and oral EGCG, right? And oral, reishi mushroom. But you can often get them in tinctures or maybe even as part of creams and use them on the scalp for hair loss. And so I did look up, you can see EGCG, so testosterone-induced apoptosis of hair follicles was reduced by topical EGCG. It was a mouse study, but you can find topical EGCG. It's out there. Just know your source, and you can apply it if you have somebody maybe at the temples, or if you have somebody who's losing it in the crown of their head or their hairline, and then having them use it consistently, and then go back to that Ganoderma and microneedling option where again it was topical into the scalp. Spearmint tea drank 2 times a day, you can see there. So it didn't affect hirsutism, but it did lower androgens. This was specifically with PCOS. And for a lot of you know this, or you've heard this statistic before, I just wanted to provide the study that showed spearmint tea 2 times a day. You could also consider maybe spearmint tea as one of your, or spearmint tea. Well, you could do spearmint tea as a rinse on your hair. or spearmint essential oil in your mix of essential oils with your carrier oil. I didn't find topical spearmint and androgenic, just I found the tea study, but it's worth a shot if you've tried everything, right? And then anecdotally, people report mixing garlic, honey, and onions and either cinnamon or capsaicin on the scalp to be helpful for male and female pattern baldness. This is anecdotally, but I do hear it a lot, or somebody's like, oh, I made, I boiled garlic and onions and got a paste and put that on, or I use capsaicin for scalp support. And so you will hear it. If high cortisol is the issue, and I know that we are a little over time, but I want to make sure I get through cortisol. Now, these slides, thankfully, I've gone over a lot in 2020. I've talked about cortisol and resiliency and cortisol awakening response. So this is definitely for those of you who are newer to what do you do with high cortisol? How do I treat that? So you always, of course, want to address the cause. So you want to address how they're handling the stress, how they're dealing with the stress, how they're releasing the stress. Is it because of blood sugar dysregulation? Is it because of inflammation or infection? Maybe they're using prescription cortisol or a hydrocortisone cream, which is cortisol. Hydrocortisone is cortisol. It's a stupid naming thing by pharmaceuticals. So we know, seek therapy if you need it. Don't be a hero. Seek out help. Seek social connection as best that you can. Meditation, breath work, journaling, yoga, heart math, respirate, emotional freedom technique. Whatever you do in your practice and you're teaching to your patients, keep it up. Grounding exercises, having them go for walks, having them get fresh air as the best they can. Shaking exercises, shaking are literally like what dogs do after they play, is they shake it off, right? So having them when they have a stressful event, shake out their hands, shake their body, do dance, put on good music and do a couple minutes of dancing. That movement and shaking in essence kind of closes the loop of stress. If you've ever read the book, Why Don't Zebras Get Ulcers? He talks about it in there. It's basically a Taylor Swift mixed with Frozen, Let It Go. So you're going to shake it off and let it go, and that's it. But it's a physical movement. You're going to do vagal nerve exercises. So you're going to hum, you're going to gargle, you're going to wash your face in cold water. You're going to end your shower in cold water. You're going to increase oxytocin. So you're going to do all the loving, bonding, happy things. You're going to pet your dog. You're going to snuggle your cat. You're going to have great bonding time with your partner and your family and your kids. If you breastfeed, it's what comes out when you breastfeed. And you're going to reduce cell phone exposure and EMF exposure to the head, which could be inflammatory, driving up CRH, ACTH, and then cortisol. Calming support, your typical calming supports, think of like GABA, think of pregnenolone, think of your calming amino acids, theanine, 5-HTP, tryptophan, taurine, which isn't technically an amino acid, but kinda. And again, in the interest of time, and I've gone over this so many times, I'm gonna move through it, but all the notes are here for you guys because I want to make sure I don't miss any good questions. Just as a reminder though, if you do use 5-HTP or dopamine support, they have the same rate limiting step and you can deplete each other. So don't just give 5-HTP forever or dopamine support forever because you will deplete the other one because of this step right here. Calming herbs, magnolia, ziziphus, and skullcap. On the Dutch test, we look at if they're leaning more towards 11-beta-HSD1, which is the enzyme that activates cortisol. These herbs are the anti. They're going to deactivate, so lower cortisol, so it's not floating around as much. So in that woman, the case study, like these would be really good for her while she's doing whatever she can to manage her stress, but these things could be helpful for her in the morning so she doesn't feel like a 10 out of 10. And then the calming stuff that we know, chamomile, avena, passion flower, maca, and of course, hemp-derived CBD. Adaptogens, ashwagandha, Siberian ginseng, rhodiola, and holy basil. Super common. Just be careful with rhodiola. Some people can get stimulated from it, and it's dose dependent. Other ones, cordyceps, schisandra, and bacopa. Again, calming adaptogens, I have the information here. And then sleep function. This is kind of a no-brainer, but I just want to make sure you remind, your patients now that are addicted to Netflix and they're working from home and they're on their computer all day and they've got screen strain and then they're doing the lights at night and they're not winding down and they're stressed out, so they're drinking alcohol and then they can't figure out why they feel like crap and they can't sleep and they're putting on weight. remind them about the basics of sleep hygiene and the importance of darkness of room, the importance of winding down, the importance of, you know, being mindful of their alcohol intake, their sugar intake, their snoring, their breathing, you know, who sleeps in their bed with them and is waking them up. And then we have the very last thing is just as a quick reminder, autoimmune and cortisol. So alopecia areata and totalis, if it is autoimmune, low cortisol can make it worse. So we've talked about high cortisol making it worse. Low cortisol can really make it worse as well. So if you do a Dutch plus and their cortisol awakening response is low, that can affect many things, but autoimmune. So if you recall, glucocorticoids are strong inducers of apoptosis in the thymocytes. Your thymus gland sits right behind your breastbone right here. Your thymus gland is really important for immune maturation. So T cells in your thymus gland have to go through maturation. So what it does eventually is it differentiates to a double positive, but you can't have that. It has to be either a CD4 or a CD8. These are your options. Unfortunately, apoptosis gets the better of most of them, and most of your T cells die just because apoptosis takes over. What does survive goes through central tolerance. Your thymus gland will check it to make sure that that T cell is not reactive to anything in your body. We don't want to create an accidental autoimmune T cell. We want our T cells to be killing external stuff, right? Like things created out of the body, not internal stuff like thyroid tissue. And if they pass, if they don't react to anything, then they graduate and they become either a CD4 or CD8, and they get pushed out into circulation upon graduation. But if they fail, if they accidentally react to something, let's pretend thyroid, and now it's a Hashimoto's, so to speak, T cell, then they have to die. The thymus gland has to go, oh, you can't do that, we have to kill you. One of the things that helps stimulate the death of that is the cortisol awakening response. So a healthy, normal cortisol awakening response. If you're flatlined, if you are low in your cortisol awakening response, then that accidentally created T cell that's autoimmune slips out into circulation and can cause problems. Thyroid is my example. It could be anything. It could be against, you know, ovarian tissue, it's synovial fluid, brain something, you know, like any kind of autoimmune. So we definitely always want to check your cortisol awakening response when you're working with autoimmune, because it could be one of the things just added to it. So the take-home message, if you have a low or flat cortisol awakening response, your risk for autoimmune increases. You can't kill those failed T cells. And if you have no idea what I'm talking about in the last 2 minutes, I have a webinar on it, and it's about 60 minutes. That's not true. It's about 75 minutes. And it's free, and it's on the Dutch website, and you can go watch it and learn all about autoimmunity and cortisol. So in summary, to always address the cause of hair loss as best you know. But know that it's like churning a cruise ship. So if your patient calls back pissed that in 30 days they don't have hair growth, be like, I know, I told you, it's probably going to take 2 to 4 to 6 months before you start to see the cruise ship turn. So you have to be consistent in what you do every single day. You can't stop or take breaks because you're frustrated, and it is going to take time, but it could definitely come back greater and better and stronger than ever. So focus on scalp health. Focus on keeping that hair in the anagen phase, focus on improving hair follicle health, and use the Dutch Plus to evaluate your androgens, your cortisol, and the other hormones like estrogen that play a role in hair loss. So practitioners, I don't want you to get your hair lost out of your scalp either. So please don't be like Cruella de Vil, who's trying to do everything, and as a result, your high stress and your giving attitude and your giving generosity makes you lose out all your hair. Don't do that. Take care of yourself too. If you're new to Dutch, if you're listening to all this and you're thinking to yourself, this is amazing, Carrie is the most amazing speaker I've ever heard, and this test sounds fabulous, you too can sign up. You can receive up to 50% or 50% off up to 5 kits when you buy. So your first 5 kits will be 50% off. We are here to help you. We have a team of doctors here to help you. We have a sales team here to help you, a customer service team to help you. So please feel free to ask any questions about signing up or about the webinar. So again, I apologize. We went 15 minutes over, but it was 111 slides, and hair loss is so fascinating that I wanted to give all of it to you.
Thanks, Carrie. So I've got a few
Yeah.
questions I wanted to run past you. So in your research for this presentation, and just in general, maybe some of the docs, your clinical consultants have talked about it. Have you seen any increase in hair loss due to COVID-19 and possibly because of any particular steroid treatment that maybe has been prescribed because of a COVID-19 diagnosis?
So that's a really good question. Yes, because of the pandemic in general, but it's too new for us to see like post-COVID syndrome. That we are not seeing that come through on requisition forms yet, but absolutely are we seeing help, I'm losing hair, I've been losing hair this year, or even just in conversation where people are saying they've been having a lot of hair loss the last 2 months, 4 months, 6 months. Everything started since COVID or since, kids went back to school, but it's homeschooling and it's so hard. But the actual post-COVID syndrome or post-COVID treatment of using corticosteroids, we have not seen yet. I would imagine, though, we will start to see that here in the next couple months.
Yeah.
And then I can report back.
So this goes back earlier in your presentation. How do you know how to test for a mast cell levels in scalp?
So in the research, they were doing the biopsies. So in some dermatology offices, obviously you can do like a scalp scraping where they'll check for fungus, but you can also get a full-on scalp biopsy. And then the research, they were looking for mast cells in the biopsy as well as looking for other things. So that's super invasive, but it was, I just saw it over and over again.
So when you were talking about using the essential oils in the scalp, do you have any guidelines or did you come across any guidelines on how long you would keep that on the scalp?
That's a good question. I did not. And a lot of it is anecdotal that I've read of people's either success stories on the mouse, right? What they put on the mouse. And sometimes when they were injecting it, they obviously just inject it and leave it. And when it was topical, they were just putting it on the mouse and leaving it. But other people, I mean, there's even shampoos with rosemary oil built in it, or people are putting rosemary essential oil in their shampoo and using it every day, or their conditioner. They'll condition their hair with the oil in it and leave it on their scalp for a couple minutes and then rinse it off. So unfortunately, I don't have a hard and fast guideline. The mouse studies seem to put it on and leave it on because it was a mouse. So in your work from home people, if they don't have to be on camera, maybe telling them do a hair mask and, try to leave it on for 30 minutes or an hour before you rinse it off a couple times a week. And then in between there doing just the quick treatment in the shower.
Okay. So this is maybe a little outside of what you presented on, but maybe you've run across this in your practice. Do you have anything to say about potentially sudden loss of eyelashes when you've got a female patient who's at the early stages of menopause and what you would do with that?
I actually hear that. So eyelashes can be all the same reasons. So eyelashes can be autoimmune, eyelashes can be thyroid, eyelashes can be iron, eyelashes can be androgenic, eyelashes can be the shift in estrogen and progesterone. So I definitely see that. And obviously there's all sorts of natural and not natural eyelash serums out there to help your eyelashes grow back. I tell you, like I said earlier, this is just me personally. I use castor oil on my eyelashes, just rubbing it over my eyelashes to help my eyelashes and my eyebrows be healthy and strong. But I have not looked specifically into eyelash regrowth research. All the research I was on was hair on the scalp. I didn't focus on like how to like do the same. Like I would never, I don't know that I would put like turmeric on your eyelash.
Yeah.
Like be careful on some of the, like think through some of these things before you just jump in and do it. Or check the literature. Like maybe there is literature on EGCG topically and the eyelash, or turmeric and the eyelash. I didn't search for it.
Okay. Any recommendations or any favorite collagen brand that you would recommend?
Favorite collagen brands? That's a good question. I'm trying to think of the collagen that I have downstairs. So I have no affiliation, you guys. Nobody, Dutch doesn't affiliate with any supplement company. I'm trying to think. Like like downstairs, I think I have two. I think I have designs for health collagen, and I think I have which I think I just ran out of. And then I have another one. It has reishi mushroom in it. And it's in a brown canister, and they like test for mycotoxins stuff. Isn't that terrible? Like I know what it is, but you know what, you guys, this I'll tell you, this is a plug for a friend of mine who's another ND, Dr. Christian Gonzalez. He has a podcast called the Heal Thyself podcast, and he got all of the COAs from multiple collagen companies, and he does a podcast on it, going through who has the best, cleanest, healthiest collagen from multiple types. So I'd honestly follow what Christian does, because he does all the hard work. He pulls the COAs, he sees what they test for, he sees how transparent companies are, and then he just shows you, and then you can make a recommendation from there. So listen to Christian's podcast, and then you can make a decision.
So did you come across, again, if there's any evidence for caffeine-based shampoos or keratin topical for or oral for hair growth?
That's a really good question. You know what? I didn't look into either of those. I didn't think of looking into either of those. I've heard anecdotally the caffeine, but I don't know the research behind it. And same for keratin. I have, like, in fact, because I love my hair, I have a keratin sort of like hair serum that I use because I got sucked into the marketing. But I don't know that it's actually working. But I didn't look into keratin. I just looked into silica because that's one of in collagen, because those are just time. We had 60 minutes, so it's time. So I'll have to look into those. We'll have to do a longer webinar, Amy, and I'll have to look into all of this.
I'll make this well, actually, I've got two more. So one would be on Sorgens and hair loss. Do you have anything? Have you ever come across that?
On what now?
Sorgens disease and hair loss.
Sjogren's and hair loss. Being autoimmune, did I not list Sjogren's is in that list with alopecia? I think Sjogren's is supposed to be in that list, and I must have left it out. But this list, let's just fly back in time real quick. Actually, we'll just do this. With alopecia, this list here, I apologize, you guys. I think Sjogren's is supposed to be on this list. So yes, there is a link between Sjogren's and alopecia.
Okay. If you can repeat one more time the name of the podcast for the collagen supplements.
Heal, H-E-A-L, Heal Thyself podcast. You can find it on Apple, iTunes, Spotify. And then it's Dr. Christian Gonzalez. And he does it for lots of things. He does it for fish oil. He does it for protein powders. He does it for cacao powder, which is so sad because my cacao powder has heavy metals in it. He does it for collagen, and he has no affiliation. He just collects all the COA data and then presents it to see who's transparent, who's testing, and what they found.
Okay, so that is going to be the last question. One thing I want to say, I know we've got a few patients on the line here, so just to kind of globally answer this question, no, Dr. Jones does not see patients at this time. If you are interested in finding a provider in your area, the Dutch website, if you go to dutchtest.com, we do have a find a provider feature, and you can search in your area to find a practitioner who tests with Dutch, and would also, that practitioner would also have the ability to consult with our Dutch consulting staff, which is led by Dr. Jones, about your test results. In addition, if you are a patient and you've purchased a Dutch test from us, I would recommend doing the same thing, going to dutchtest.com and searching our find a provider to, again, find a provider that's already using Dutch testing, and they can help you with your test results as well. So I want to thank everybody for joining us this afternoon, and just mention again, we will be sending a copy of the slides along with the on-demand recording, so you can listen to this again. And then any of the other webinars that Dr. Jones has done this year, you can find under our education navigation on dutchtest.com. We've put on a great series of webinars all this year in 2020. And as Carrie mentioned, we've done specifically talked a lot about stress and resiliency a lot this year, just because of the nature of what 2020's brought all of us. So we look forward, we wish you guys happy holidays and happy new year, and check back with us in January, because I'm certain we're going to be starting up again. Thanks, everyone. Thanks, Carrie.
Thank you.